Welcome to the Hospital Medicine Unplugged podcast.
Today we're doing an essential deep dive. We're looking at the modern evidence-based management of acute appendicitis, specifically in hospitalized adults. For years, maybe decades, the default was just immediate surgery.
All right, straight to the OR.
Exactly. But the recent high-level data really demands we think differently, shift towards more precision medicine.
And that shift is precisely what we need to unpack today. Our goal is to really distill the latest guidelines, the high-quality evidence, especially from journals like JAMA and NEJM. We want to focus on how good risk stratification, advanced imaging like CT, and these validated non-operative strategies can help us optimize care.
Yeah, particularly for the hospitals who's often guiding that initial workup, maybe even complex discharge planning later on.
So the focus isn't just diagnosing appendicitis anymore, is it?
Not at all. This deep dive has to go beyond just saying, yes, it's appendicitis. It's all about accurately classifying the severity up front. We're aiming for a system where the treatment pathway, immediate surgery, antibiotics-first, maybe delayed intervention, is dictated by very specific clinical and, importantly, radiological findings.
Okay, let's get into it then. First, let's just set the stage. How big a problem is acute appendicitis?
Well, it's still the most common abdominal surgical emergency globally. The numbers are pretty significant annually, something like 96.5 to 100 cases per 100,000 adults. That translates to a lot of hospital admissions.
A huge volume.
Yeah.
And the lifetime risk for an average person.
It nets out to about 7 to 8%. But honestly, for us managing these patients acutely, the raw incidence isn't the main concern. It's identifying who's predisposed to severe disease.
Okay, so who are the high-risk patients? We often hear young males have the highest incidence, right? Something like 8.6% lifetime risk versus 6.7% for females.
That's true for overall incidence, but when you look at predictors for complications, things like perforation, abscess formation, the factors shift. It's less about young males and more about the patient's age at presentation and how long they've had symptoms.
Ah, so the drivers for bad outcomes are different.
Exactly. The things that really push towards adverse outcomes are increasing age, especially patients over 65. Also, significant comorbidities, think diabetes, immunosuppression, and critically, the duration of symptoms.
How long is too long?
Well, delayed presentation, usually defined as symptoms going on for more than 12 hours, and certainly over 48 hours, that's probably the strongest independent predictor for perforation. So that older patient, maybe with multiple medical problems, who waits a couple of days to come in, that's the highest risk profile we need to manage carefully.
Makes sense. And there are some non-clinical factors too, right? Like diet, family history.
Yeah, briefly, associations exist with lower dietary fiber, a positive family history, even lower socioeconomic status. Interesting from an epidemiology perspective, but maybe less critical for the acute management decisions once they're in the ED.
Right, our focus shifts to the pathophysiology at that point. What's happening inside?
The core issue is obstruction of the appendiceal lumen. That's the starting point. Now, what causes the obstruction often varies with age.
How so?
In younger adults, it's frequently lymphoid hyperplasia, basically, overgrown lymphoid tissue.
Yeah.
But in older patients, you're more likely to find a heart obstruction, like an appendicolith, which is a calcified deposit, or a fecalith.
And why does that distinction matter?
It's critical because finding an appendicolith on imaging significantly increases the risk of perforation. And, as we'll discuss later, it's a major predictor that non-operative antibiotics-first management might fail.
Got it. So the obstruction kicks off a cascade.
Precisely. It's a vascular cascade. The pressure inside the appendix lumen rises. First, it exceeds venous pressure, so you get venous congestion, impaired lymphatic drainage, the appendix swells.
And then?
As the pressure keeps climbing, it compromises arterial flow. The small vessels become ischemic, they can thrombose. This leads to tissue damage, specifically necrosis of the mucosal barrier.
And that's where bacteria come in.
Exactly. Once that barrier is breached, the gut bacteria normally kept in check start to rapidly overgrow. We're talking primarily firmicutes, proteobacteria, Bacteroides, actinobacteria.
Knowing those specific groups must inform antibiotic choices.
Absolutely. We know we need broad coverage, especially against gram-negatives like E. coli and anaerobes like Bacteroides fragilis. It's this bacterial invasion on top of the ischemia and inflammation that drives the progression from simple inflammation to full-thickness necrosis and ultimately perforation.
Okay, that progression logically leads us to how we classify appendicitis, which seems crucial for management.
It really is. The most practical way for a hospitalist to think about it is a binary classification. Uncomplicated versus complicated appendicitis.
Define uncomplicated for us.
Uncomplicated is very specific. It means inflammation is confined to the appendix itself. There's no CT evidence of perforation, no surrounding abscess, no phlegmon, which is sort of like a walled-off inflammatory mass, and no generalized peritonitis. These are the patients who might be candidates for an antibiotics-first strategy.
I think complicated.
Complicated is defined by the presence of any of those things: perforation, abscess, phlegmon, or diffuse peritonitis. These automatically signal higher morbidity and generally mean the patient needs surgery plus antibiotics for source control.
Is there a more detailed grading system? I've heard of the AAC system.
Yes, the American Association for the Surgery of Trauma system grades severity from grade 1, just an intact inflamed appendix, up to grade 5, which is perforation with widespread purulent peritonitis. While useful for research and documentation for the hospitalist making initial decisions, distinguishing, say, a grade 2 phlegmon from a grade 4 gross perforation using the CT findings is key. That distinction often determines if immediate surgery is needed versus maybe trying antibiotics or drainage first.
Okay, so classification drives the plan. What about the initial clinical assessment? We all learned the classic signs.
Right, the periumbilical pain migrating to the right lower quadrant, that happens maybe 50–60% of the time. Anorexia is pretty common, 80–85%, right, lower quadrant tenderness on exam, over 90%. And labs often show a mild leukocytosis, maybe over 10,000, often with a left shift in about 80%.
But the experienced hospitalist knows not to rely just on the textbook picture.
Absolutely. The atypical presentations are where patients get into trouble, where diagnosis is delayed, leading to complications. Relying only on classic features is, frankly, dangerous in some groups.
Which groups are particularly challenging?
The elderly and the immunocompromised are top of the list. They often have much more subtle symptoms. Pain might be less localized, maybe minimal or no fever, and crucially, they might not even mount the significant leukocytosis. You need a very high index of suspicion in these patients because they're the ones most likely to already have perforated by the time they present, precisely because the early signs are missed or downplayed.
Location variance too, right? If the appendix isn't in the usual spot.
Definitely. A retrocecal appendix tucked behind the cecum can cause flank pain or back pain easily mistaken for pyelonephritis or kidney stones. A pelvic appendix can irritate the bladder or rectum, causing urinary symptoms like frequency or dysuria, or even tenesmus, feeling like you need to have a bowel movement. These symptoms can really throw you off if appendicitis isn't high on your differential.
So given this wide range of possibilities, the differential diagnosis has to be broad, but also targeted at ruling out the immediate threats.
Non-negotiable. You have to rapidly exclude the life-threatening mimics.
What are some common things that look like appendicitis?
Well, gastroenteritis can sometimes mimic it, especially infections like Yersinia enterocolitica, which causes inflammation near the appendix area, the terminal ileum. Mesenteric adenitis, swollen lymph nodes in the abdomen, is common especially in younger people. Ureterolithiasis, kidney stones, is a big one for right lower quadrant pain. A urinalysis is key, but remember, some inflammation from appendicitis can cause a few red or white cells in the urine too, so it doesn't definitively rule it out. And right-sided diverticulitis, while less common than left-sided, can present almost identically. Crohn's disease flare is another possibility.
Okay, those are common. What about the can't-miss diagnoses?
The really urgent ones require immediate action. In any woman of childbearing age, you must get a urine beta-HCG to rule out a ruptured ectopic pregnancy. Ovarian torsion is another emergency in women, and particularly in older patients, maybe with known vascular disease or risk factors, you have to consider a ruptured abdominal aortic aneurysm and RAA. That might need a very quick CT scan or even a point-of-care ultrasound at the bedside if they're unstable.
Okay, so clinical suspicion is high, differentials considered, we need objective data. Let's talk diagnostics, starting with labs.
Standard is the CBC with differential. We look for that leukocytosis and left shift. But we have to be honest about the limitations. Sensitivity is maybe 70–80%, specificity even lower, around 55–65%. So a normal white blood cell count absolutely does not rule out appendicitis.
Is there anything more helpful from the labs?
The C-reactive protein, CRP, can sometimes add more value, especially for prognosis. A significantly elevated CRP, particularly when combined with a high neutrophil count, seems to correlate better with complicated disease like perforation or abscess than just the total white count alone. It can be a clue towards increased severity.
And don't forget the rule-outs.
Absolutely. Urinalysis and the urine beta-HCG remain essential baseline tests.
What about risk scores? Things like Alvarado or RIPA-SA.
These scores can be useful tools, but it's important to understand how they're useful. Their main strength is in identifying the genuinely low-risk patient. Someone with a very low score might be safely observed or maybe only needs a limited imaging study, like an ultrasound first. They help guide the decision flow, potentially avoiding immediate CT for everyone.
But for intermediate or high scores?
For those patients, or frankly anyone with unclear clinical signs, most centers in the U.S. are going to move pretty quickly to CT imaging. The stakes are just too high to rely only on a clinical score when definitive imaging is readily available.
Which brings us to the gold standard in adults. CT scan of the abdomen and pelvis.
Yes, CT is first line in the vast majority of centers. Its performance is excellent sensitivity, usually quoted between 91 and 96%, and specificity between 90 and 94%. It's very accurate.
But its value goes beyond just saying yes or no to appendicitis, right?
Absolutely. CT is indispensable because it's the single most critical tool we have for risk stratification. The findings on the CT scan dictate the entire management strategy. It tells us if it's uncomplicated or complicated.
So what specific CT findings are we looking for that indicate higher risk, or maybe suggest that antibiotics alone won't work?
There are three main high-risk features we look for. First, the presence of an appendicolith, that calcified stone we mentioned. Second, signs of a significant mass effect, meaning inflammation causing pressure or displacement of nearby structures. And third, probably most importantly, significant dilation of the appendix itself.
Is there a specific size cutoff?
Yes, typically an outer diameter of 13 millimeters or greater is considered high risk. That 13 millimeter mark isn't arbitrary. It strongly correlates with a higher likelihood of transmural necrosis, meaning full thickness damage to the wall and either impending or actual perforation.
And the appendicolith.
If an appendicolith is present, the reported failure rate for non-operative management jumps significantly. Some studies suggest over 40%. So finding an appendicolith really pushes the balance towards surgery being the better initial option.
That's a critical piece of information for having that shared decision-making conversation with the patient about antibiotics versus surgery.
Fundamental. If we're considering non-operative management, we and the patient need to know if these radiological risk factors are present because they significantly lower the chances of success with just antibiotics.
What about CT protocols? Contrast, low dose.
Generally, IV contrast is preferred. It helps highlight the enhancing appendiceal wall, shows surrounding inflammation or fluid collections better, and helps differentiate from blood vessels. Oral contrast usually isn't necessary these days and just adds time to the study. And a key point, especially for younger adults and adolescents, is to use low-dose CT protocols whenever possible. We can maintain excellent diagnostic accuracy while consciously minimizing their lifetime radiation exposure.
Okay. What if CT isn't the first choice, say in children or pregnant patients?
Right. In those cases, ultrasound is typically the initial imaging modality, primarily because it avoids ionizing radiation.
But it has limitations.
Significant limitations. Ultrasound is very operator-dependent. Its overall sensitivity and specificity are lower than CT. And a major issue is that the appendix often isn't visualized, maybe due to the patient's body size or overlying bowel gas. And critically, non-visualization does not rule out appendicitis. An inconclusive ultrasound just means the question hasn't been answered.
So what happens if the ultrasound is inconclusive in a pregnant patient or a child?
Then MRI becomes the preferred second-line test. MRI is highly accurate for appendicitis, gives great detail of the soft tissues, and importantly, it's safe in pregnancy, poses no risk to the fetus. So it's the go-to problem solver when ultrasound doesn't give a clear answer in those specific populations.
Okay, so we have the diagnosis, we have the risk stratification from imaging. Let's move to management strategies. What are the first steps?
Regardless of the eventual plan, everyone needs general supportive measures up front. That means IV fluids patients can be dehydrated or third spacing fluid. Bowel rest, so NPO initially, good pain control, analgesia, and antiemetics for nausea or vomiting.
And antibiotics.
Preoperative antibiotics are crucial. They're indicated for all patients heading to surgery, even if the appendix looks uncomplicated on CT. Giving that dose before incision significantly cuts down the risk of surgical site infections later.
Now let's talk about the big shift, the antibiotics-first approach, or non-operative management, NOM.
Right. This has been validated now by several large, well-done, randomized controlled trials, like the APAC trial from Finland and the CODAD trial here in the US. They've established NOM as a safe and effective option, but, and this is key only for strictly selected, uncomplicated cases.
That selection piece sounds critical. What are the criteria?
They are rigorous. Patients must have CT confirmation of uncomplicated appendicitis. Specifically, they cannot have any of those high-risk CT findings we discussed. No appendicolith, no abscess, no phlegmon, no significant dilation, usually beyond 10-11 millimeter in those trials, and certainly no signs of generalized peritonitis.
And for those carefully selected patients, what are the outcomes?
The initial success rates with antibiotics alone are pretty good, approaching 70% in well-selected groups. Plus, studies consistently show some patient-centered benefits, things like lower reported pain scores during recovery, and often a faster return to work or regular activities compared to those who have immediate surgery.
But there's a trade-off, isn't there? The risk of it coming back.
That's the absolute crux of the shared decision-making conversation. You're trading the certainty of surgical removal for a known risk of recurrence down the line. While antibiotics work well acutely for that initial episode in most selected patients, the recurrence rate isn't trivial. It's estimated around 30% at 1 year and maybe climbs close to 39% by 5 years. The patient absolutely has to understand this long-term possibility when they choose NOM.
What antibiotic regimens are typically used?
You need empirical broad-spectrum coverage, targeting the likely culprits like E. coli and anaerobes. Common initial IV regimens include ertapenem as monotherapy. It's got great coverage and once-daily dosing. Or a combination like an IV cephalosporin, maybe cefepime or ceftriaxone, plus metronidazole for anaerobic coverage.
And then transition to oral.
Yes. Once the patient shows clear signs of improvement, fever resolves, pain is much better, they're starting to tolerate liquids or food, you can transition them to an outpatient oral regimen. Typically, this involves a fluoroquinolone combined with metronidazole continued for a total course of maybe 7 to 10 days.
Is there a protocol for if the antibiotics don't work?
Absolutely essential. There must be clear criteria for failure. Patients on NOM need close monitoring. If they show any signs of clinical deterioration, worsening pain, developing peritoneal signs, persistent fever, or tachycardia, or if they just fail to improve significantly within about 24 to 48 hours of starting appropriate antibiotics, the plan must be to cross over to surgery. That threshold for intervention is critical for safety.
Okay, now shifting gears to complicated appendicitis, perforation, abscess, phlegmon. The path seems clearer here.
Much clearer. For complicated appendicitis, definitive intervention is required. Surgery remains the standard approach, and laparoscopic appendectomy is strongly preferred over an open operation whenever feasible. The benefits are well established: faster recovery, shorter hospital stays, fewer wound infections.
The key concept here is source control, right?
Exactly. You have to control the source of the infection. For gross perforation with contamination, that means surgically removing the appendix and washing out the abdomen. If there's a well-contained abscess or a large phlegmon, source control might sometimes be achieved initially with percutaneous drainage guided by interventional radiology, often followed by antibiotics, and sometimes a delayed or interval appendectomy weeks later.
How do you decide between immediate surgery versus IR drainage for an abscess?
It's often a multidisciplinary decision involving surgery and IR. It depends heavily on the size of the abscess, its location, whether it seems well walled off, and the overall clinical stability of the patient. A large, accessible, contained abscess might be amenable to drainage first. Diffuse peritonitis or instability usually mandates immediate surgery.
And the antibiotics for complicated cases?
They need to be aggressive and broad spectrum right from the start. You need reliable coverage against gram-negative rods and anaerobes. Common choices include agents like piperacillin tazobactam or ertapenem, sometimes broader agents if there's concern for resistance. The goal is to manage the significant bacterial load from the contamination.
Let's talk about care after the initial treatment, whether it was surgery or antibiotics. How does it differ?
It needs to be tailored very specifically based on what the initial problem was and how it was managed. Let's take the straightforward case first. Someone who had surgery, say a laparoscopic appendectomy, for uncomplicated appendicitis.
Okay.
For them, postoperative antibiotics are generally not needed. They got their single preoperative dose for surgical site prophylaxis, and that's usually sufficient. There's no benefit to continuing antibiotics after the source is removed in uncomplicated cases.
So the focus is on recovery.
Exactly. Early mobilization, advancing the diet as tolerated, aiming for discharge often within 24 hours after a straightforward laparoscopic appendectomy. It's about efficiency and minimizing hospital stay.
Now contrast that with the patient who had complicated appendicitis, maybe perforation or an abscess, and underwent source control, surgery or drainage.
Big difference. These patients do require continued antibiotics after the source control procedure. The standard recommendation is typically 3 to 5 days of continued broad-spectrum therapy. You transition from IV to oral antibiotics as soon as they are clinically stable and tolerating PO, aiming for that total duration.
Why the continued antibiotics?
Because even with source control, there's residual contamination and inflammation. The antibiotics help clear the remaining infection and reduce the risk of developing secondary complications, like another intra-abdominal abscess forming later. These patients also need a much closer monitoring post-procedure.
You mentioned interval appendectomy earlier. Is there other important follow-up, especially for those managed non-operatively?
Yes, a really vital point for hospitalists managing discharges. For adults, particularly those aged 40 or older, who were successfully treated non-operatively for appendicitis, follow-up imaging, and importantly, a colonoscopy are strongly recommended several weeks or months later.
Why the colonoscopy specifically?
It's a crucial screening step in that age group. Sometimes, especially in older adults, what initially presented as appendicitis was actually caused by an underlying tumor at the base of the appendix or in the cecum, like a mucinous cystadenoma or even an adenocarcinoma obstructing the appendix. The initial inflammation might resolve with antibiotics, but the underlying cause remains. The interval colonoscopy aims to definitively rule out such a neoplasm.
That's a critical point to ensure it isn't missed in follow-up planning. Now let's compare the complication profiles between uncomplicated and complicated disease.
The difference is stark. For uncomplicated appendicitis treated with surgery, the risk of major complications is very low. For those treated non-operatively, the main complication is treatment failure, meaning they eventually need surgery anyway. That cumulative failure rate within the first 30 days or so is around 21%. Wound infection risk is low overall.
And for complicated appendicitis?
The profile is much more severe. A significant percentage, maybe up to 20%, of patients with perforated appendicitis will go on to develop a postoperative intra-abdominal abscess, which might require repeat drainage or even surgery. Other major risks include sepsis, prolonged ileus, where the bowels don't wake up quickly, requiring longer NPO status, and sometimes NG tubes, and overall postoperative complication rates can be as high as 24%, sometimes involving ICU stays.
Finally, let's touch on prognosis. How does it differ?
For uncomplicated appendicitis, the prognosis is generally excellent. Recovery is usually quick, and 30-day mortality is extremely low, maybe in the range of 0.05 to 0.1%.
That's very low.
Very. But for complicated appendicitis, the prognosis is definitely worse. Mortality rates are higher, perhaps closer to 0.15% compared to maybe 0.02% for uncomplicated when adjusted. And maybe more significantly for hospital course, patient recovery takes much longer. Hospital stays are substantially prolonged due to the infection, the procedures, and potential complications.
And patient factors play a big role too, presumably.
Absolutely. Underlying patient factors are often the ultimate determinants of outcome, regardless of whether it started as complicated or uncomplicated. Advanced age, underlying frailty, significant comorbidities like diabetes, heart failure, or immunosuppression, these all profoundly increase the risk of adverse outcomes at every stage.
Are there tools to help quantify that risk?
Yes, we should be using tools like the NSQIP surgical risk calculator or validated frailty indices. These can help objectively estimate a patient's risk for major complications or mortality, which is incredibly useful for informing discussions with the patient and family, guiding surgical consultation, and planning the intensity of post-operative care. They help predict who's at highest risk for things like sepsis, needing prolonged ventilation, or just failing to recover smoothly.
So the evidence really pushes us away from a one-size-fits-all surgical reflex.
Definitely. It compels us towards a highly individualized, risk-stratified approach based on solid clinical assessment and critically detailed radiological findings.
Okay, let's try to summarize the main takeaways from this deep dive.
I think number one is the central role of CT imaging. It's not just for diagnosis anymore, it's primarily for precise risk stratification. Identifying those high-risk features like an appendicolith or that appendix diameter greater than or equal to 13 millimeters is key, because that really pushes patients towards needing surgery.
That's okay.
We need to fully embrace shared decision-making for uncomplicated appendicitis. Both laparoscopic surgery and the Antibiotics-First approach are valid, evidence-based options, provided the patient meets strict selection criteria for NOM and fully understands the significant recurrence risk associated with choosing antibiotics alone.
And for complicated disease?
Complicated disease demands prompt, aggressive source control, whether that's surgery or sometimes IR drainage, coupled with targeted broad-spectrum antibiotics. There's less ambiguity there.
All right. So let's end with a final provocative thought for our listener.
Given the proven safety and increasing use, even validation of oral, outpatient, non-operative management for selected, uncomplicated cases, and considering that the incidence of perforation, often due to delayed diagnosis, seems to be stable or maybe even rising, maybe the fundamental goal of our entire diagnostic workup needs to shift.
Shift from what to what?
From simply asking, is it appendicitis, to more importantly asking, how severe is this appendicitis, right now, preemptively? The classification becomes paramount from the moment of suspicion.
And the downstream effects of that shift, especially with more outpatient NOM.
Well, think about it. How will the growing comfort with sending selected patients home on oral antibiotics drastically reshape hospital resource use? Things like operating room time, inpatient bed needs, and maybe even challenging the deeply ingrained surgical culture that has traditionally viewed appendicitis almost exclusively through an operative lens.
The implications for how we practice hospital medicine, how we interact with surgery and radiology, seem pretty substantial and are probably already starting to happen.
They really are. It's a